I think you're going to have a hard time getting the patient into the operating room. I think you can call gynae and be like, I'm telling you this now because I am so concerned that you need to be making your way in and us not delaying for this patient where my pretest probability of ruptured ectopic is through the roof. You know, be like, I'm activating you, and there's a 2% chance I'll have to apologize to you in 30 minutes from now, but a 98% chance that I won't. But yeah, they'll probably want the beta result before they go for OR. What about if that 17-year-old who's missed a period now is presenting with 4 hours of chest pain instead of 4 hours of abdominal pain and has these vitals, and you're thinking, this is a patient who was pregnant once before, now they're back in my emergency room. I wonder if they're pregnant again. But they don't have abdominal pain, they have chest pain. So we'll start with doing some cardiac scanning. And I will wait for my team to tell me what they see. Yeah. So, you know, when we see so much normal normal views, we talk about, oh, you're looking for this thing, but we don't see it. It can mess you up when you do see it because you kind of have to pause and be like, wait, what view is this? This doesn't look normal. This is a peristernal short, but it doesn't look like a peristernal short because this doesn't look circular, right? So it's like a capital D on a bit of an angle. So what does that D tell you? Yeah, RV strain was the answer. And I will argue that it just tells you more fundamentally there's a pressure change from normal between the LV and the RV. So you could have some other kind of condition where like your left-sided pressures drop while your right-sided pressures remain normal but not high. There was a paper that came out a couple weeks ago about hypoventilating pigs and how they would develop the D sign on cardiac views. And so there probably are some things other than high right-sided pressures. But here we've got a female patient who may be pregnant and now has a finding that often is found with high right-sided pressures. So keeping that in mind, we'll do some other views. You won't see me put up very many examples of apical 4-chamber cardiac because of my preaching that like it's fairly rare that it alters things for me that I haven't yet found by doing other cardiac views. But man, sometimes you get nice pictures of pathology. So what kind of pathology would you guys say exists in this loop? Yeah, here's our RV. It's occupying most of the screen, right? And the septum's pushed over. So that you can imagine now if you do your 3D reconstruction, it's that bowing of the septum that if I cut it in one axis through the short, it looks flat, right? It's pushing in. It creates that D shape in that view, but a bowing shape in this view. So this is all this stuff here?
Yeah, I got that bit.
Well, this is the muscular wall. So the bright line inside is the endocardium. The bright line on the outside is the pericardium. And this would be septal musculature. And is it thickened? Well, it's distorted. So all I would say is that, yeah, it looks a little funny, but I couldn't be more specific than that. Is it the fact that this clip exhibits a McConnell sign, which I'll talk about in a second? Or is it just that the anatomy is being pushed around by some of the chamber dilations, making it appear abnormal? So McConnell's sign is hypokinesis of the RV apex and is one of those things that is kind of boosts your pretest probability for PE. but is also something that's relatively hard to capture. And I would say that our gross view of this and our gross interpretation is easier. That RV looks weird and big and septum's bowing. So what are you guys thinking is a possible cause for this 17-year-old female's shock? PE, yeah. And let's imagine that she's pregnant. So why do people who are pregnant get PEs? Oh, I hear amniotic.
I don't know how to say it in English, but yeah.
Are you thinking amniotic fluid embolus?
Yes.
It's possible.
Maybe.
Sure. What would, yeah, they get DVTs because pregnancy is a what state? A hypercoagulable state. So where do their DVTs come from? Yeah. Okay. So if this patient has a PE that's causing shock, what do we expect from the IVC? That it would be dilated, right? That their problem is in the circuit, they can't get blood through the lung vessels. So we expect back pressure. So we expect a view of the IVC like this. And then this is what I was telling you guys. I want that nice shot of femoral vessels where the person is not using Doppler. They're just compressing, and they're showing you that the vessels, the veins are non-compressible. But I don't have that. So I do have a view where we just have some Doppler on our femoral vessels. And you can see that there's Doppler flow here in the artery, Doppler flow here in the greater saphenous vein. So this is the groin view where the greater saphenous vein dumps into the femoral vein, and next to it we have the femoral artery. So this tells you that it's the patient's right side. But let's say this wasn't on the screen. So you know that these are the veins, and this is the artery. What side are the genitals on of this structure? Are they on the right side of the screen or the left side of the screen? On the right side of the screen. Do people here use van? Do they use navel? What's their mnemonic?
I was being told.
Which one?
Van.
Van. So I find it annoying because you got two sides, right? So you kind of always have to like imagine, which side am I talking about? Is it van or is it nav? Do I have to switch it around? So my time in New York taught me the greatest mnemonic for this. Venus towards penis. So I will never forget that. And then I will just be like, oh, Venus. Oh, so penis here. You know, that's the order in which things run. Whatever works for you, but that's the one that works for me. So
this taught me in flexible internet side or inner, and then
or Venus towards penis. So the compressibility DVT question. You know, people often like these views where you put on Doppler and you say things about them. This is a clot that's mature enough that you can actually see the clot within the femoral vessel. That indicates a longer standing clot. If you're within the first few days of having your clot, it will be completely sonalucent. You will have a black circle here, even though there's clot inside. And so the best test characteristics are for non-compressibility. You try to squish those vessels closed, but you can't. And so tips and tricks, some people squish those vessels to try to close them. They can't. They keep squishing because they're like, wait, this is supposed to collapse. And the artery itself squishes down. And that can confuse some people. They saw something compressed down. Maybe the vein is the artery. So you really have to landmark first. And you have to think, if that's pulsatile thing, is the thing I'm now squishing down. I'm adding so much pressure that I'm collapsing the artery. That's further evidence that the vein is not compressive. But really, you want to give it a good press, and you want to be very wary of a vessel that doesn't collapse when you do that. So the point of this talk was really to think about those patients that come in undifferentiated shock and all of the things that we apply to them as algorithms for diagnosis and treatment, and how point-of-care ultrasound may provide us with shortcuts.